Hello, everyone. My name is Wiegand-Shahani, and this is my presentation on vestibular migraine. Vestibular migraine is the subset of migraines caused by vestibular dysfunction, which stimulates a neurological migraine response. Before discussing vestibular migraine, we have to know about migraine in general. Migraine is a neurological disorder causing recurring headaches concurrent with other neurological symptoms, all of which are uncomfortable and painful. They are characterized by throbbing and pulsing on one side of the head. There can also be a visual aura, though that is not necessary. The cause is inappropriate activation of the trigeminal vascular pathway. The trigeminal nerve, or fifth cranial nerve, controls facial movement and sensation. When its blood supply is altered in the wrong way, the result is extremely painful projections into the thalamus and other cranial sensory regions. Migraine affects roughly 1 billion people worldwide. It is the third most common affliction out there. Vestibular problems affect roughly 44% of migraine sufferers, making vestibular migraine especially common. Although, as I will discuss later, correlation is not necessarily causation. We're just doing our best with the information we have so far. Vestibular migraine is a special subset of the causes of migraines. It is caused by vestibular hypofunction, meaning a lessening of the vestibular organs or nerves' ability to compensate for things like head movement, position changes, or complex visual stimuli. This means a lot of disorientation and dizziness. This can be unilateral or bilateral and can fluctuate, be permanent, and possibly be progressive. There are many causes for this, such as genetic disorders or Meniere's disease. However, a substantial portion of studied cases of vestibular hypofunction are idiopathic, meaning there is no known cause. The vestibular nucleus, which we all know is a bundle of nerve cells in the central nervous system, is proximal to the brainstem generator, as we can see in this picture. So, when vestibular hypofunction occurs, it activates the trigeminal pathway and its blood flow, causing migraine. Honestly, as with many inner ear and vestibular pathologies, there is more that we don't know than that we do know. This is more or less a good working hypothesis than a proven issue. Any migraine diagnosis first begins by looking at the symptoms. Vestibular migraine has its own subset of criteria. According to the Barony Society, the patient must present at least 5 episodes of migraines comorbid with other symptoms. Moderate to severe vertigo needs to be present for 5 minutes to 72 hours around the time of migraine onset. At least half of the episodes must have headaches, light or sound sensitivity, and a visual aura, which is that blurry, shimmery look things get when getting disoriented. A previous migraine diagnosis precedes vestibular migraine. All other diagnoses must be eliminated first. Once again, since not a whole lot is known about this, there are problems with our rudimentary definitions. There is no established temporal relationship between vertigo and the migraine, which widens the diagnostic criterion drastically. Exclusion of a known list of other problems, which can also be quite limited itself, does not always preclude everything else as well. We do have some diagnostic tools to pinpoint the cause and site of vestibular dysfunction. Vestibular end organ and nerve reflex testing can precipitate the problem. CVEMPs and OVEMPs test for nerve stimulation of the neck and eye orienting reflexes. Calorics irrigate the ear with hot or cold water or air, causing movement of fluid in the semicircular canals and putting the patient off balance to stimulate compensatory ocular reflexes. This is a unilateral test. Bilateral reflexes are examined by using rotary chair disorientation. Vestibular ocular reflex tests can also stimulate the same responses. One of the fun things about vestibular issues is that we are still on the forefront of treatment and management. Balance issues generally necessitate neurological physical therapy called vestibular rehabilitation therapy. This has been shown to assist in reducing symptoms and problems caused by vestibular orders like BPPV, so it is the go-to for vestibular migraine sufferers. However, there is not much empirical evidence to support its efficacy here. It should only be used in stabilized conditions where the patient is not actively getting worse or seeing variable symptoms. Neuro-PT is not used to solve problems, it is only used to facilitate the body's natural and compensatory processes. On the right, we have a picture of a common VRT procedure called the Dix-Hallpike maneuver. I won't go into too much detail about it since it is most commonly used for BPPV patients, and I know we have a presentation about that topic, but it relieves vertigo episodes and can help prevent vestibular migraine if done regularly. As VRT is not medical, it cannot correct nervous system dysfunctions or lesions like tumors. Obviously, lesions must be removed by a specialist. Certain medications or a change in diet already associated with helping migraines can help prophylactically. Things like pain relievers and blood pressure medications are helpful in some cases. Avoiding migraine triggers in general can also avoid vestibular migraine specifically. And these are my sources. Thank you for coming to my presentation, everybody.